Welcome to Lead the Way with Anna Gauker. Your guide, Anna Gauker, is on a quest of her own to find effective ways of creating change and inclusion in our communities. You have come to the right place if you believe in truth, justice, and coffee. Thanks for joining us.
Hello, this is Lead the Way, and I'm Anna Gauker. Please stop whatever you are doing and take a moment to rate and review us on Apple Podcasts. It really helps us grow and continue our mission of learning from innovative leaders. Let's talk mental health. If you're like me, then you have been extremely challenged by the never-ending twists and turns brought to us by 2020. Our guest for this episode has many key insights to offer us. Leah Rolando is Suicide Prevention Coordinator at Mental Health America of Wisconsin. We recorded this conversation towards the end of September, which was actually National Suicide Prevention Month. And during the course of the conversation, she had a lot of great things to share about how to speak up for yourself, as well as how we can all show up better for one another. Take a listen.
I think like a lot of people who come into the mental health field or the suicide prevention field specifically are usually led by lived experience with suicide. So that can mean suicide attempts or a loss of someone by suicide. And so when I was in high school, I lost a really good friend to suicide. And so kind of wanted to start talking more about mental health back in high school. And then through those conversations, a lot of friends started opening up about their own mental health struggles, their own trauma, eating disorders, all different types of things. And so that led me to get interested in some other more national organizations that talk about this on a pretty public platform.
You said that you were talking more with people in high school. Was that through an organization, or was that like an informal experience you had engaging with your friends?
Yeah, it was a little bit of both because it started informally. We were kind of a friend group who lost our friend to suicide, and we were talking about that, and we are talking with our families and wondering how to process all of it. And then I remember that my friend Ari, who died, was really into this organization called To Write Love on Her Arms. I'm sure some people might have heard of it. I think it started back in 2006, actually. And they're a nonprofit that kind of provides a public platform for talking about different mental health issues. And so I started an organization, well, kind of the high school version of that organization. It was called the Storytellers Campaign. And that was a way to bring that whole organization to our school and do a fundraiser. And I think we actually won the fundraiser in our bracket. We were a pretty small high school, and they came to our school and did a mini concert and had some spoken word. And that led me to bring it into like my college experience as well. So I also co-founded a university chapter of To Write Love on Her Arms at Illinois State University, where I attended.
And what did you major in at ISU?
Yeah, social work. It's so funny because there's a lot of stereotypes about social work if you're not a social worker, and I never really considered it until I attended my first open house at Illinois State, and I met the field director of the social work program, and she talked with me about social work, and she was like, your life experience like sounds like this is what you would be interested in professionally. And so I was like, okay, you're right. So I went into the field, or I went into school for social work and got my undergrad. So I got my bachelor's in social work. And then my mentor, she became my mentor and was the same person who told me that, I should really go on to get my master's in social work as well, and figure out what else is out there and how to connect directly with some suicide prevention work, because that field's kind of small as well. And I really wanted to learn more.
Well, I can't get too excited about ISU because I went to NIU,
Oh,
but my dad went to ISU, so that's pretty awesome.
okay. Yeah.
But how do you feel that your previous impressions of social work and then your actual experience compared?
That's a really good question. I think it helped shatter a lot of assumptions about what a social worker is and what a social worker can do. I was never personally interested. Well, I guess there's some interest in direct services and doing one on one counseling or group therapy. But I was more interested in what we call like macro work. So, more systems change and policy, program development. And I didn't have that language in the program. I just knew that I was interested in more big picture things rather than like the one-on-one kind of crisis support. And I still do. I volunteer for crisis text line. So I do some of that one-on-one support in a volunteer role. But professionally, I've learned that social work can open a lot of different doors to a variety of roles.
What was that like for you in grad school? How did you focus your energy there?
Yeah, it was cool because there were a lot of options to pick from. I remember on my first day, I don't know if it was called a field orientation, or you go to different tables of different focus areas. So they would have I think there was like a mental health concentration or mental health focus area, and then policy, and you can kind of pick and choose what your field unit was and what your concentration was. So I graduated um, with a mental health concentration, but in the field unit of policy and administration. So I kind of combined those two to build the track that I was on, and take the classes that I took.
Did you feel when you first graduated and got your first job that the work world in your profession was what you expected?
That's a really good question. So, so right as I graduated, I mean, I'll be honest, it was hard to get a job. It was really hard, even with the master's degree, to find a job that was specifically what I wanted to do. And so I had to have a little patience with myself and knowing that, like, something will come. I applied for some jobs that I wasn't, super interested in, but, you need to find a job out of grad school. And so I did, and I eventually was accepted, hired on with Mental Health America of Wisconsin, and was able to kind of change things too. I mean, I moved into this role that was already an established role, but the person before me was doing some Milwaukee County based things, and it's a grant funded position, as many of these social work roles are. And so I think that was the biggest surprise to me, because in school, I knew that things were grant funded, and I knew kind of conceptually that grants will direct what you do. But then really working and seeing the grants and see, like, okay, this is literally what's written into the grant. So these are my specific responsibilities. Um, that was really interesting to see, and how you can braid funding too to create positions, to create staff, and to create programs. And you really need to be creative if you're trying to build something that you really want to see. So I think I'm still learning a lot about that. And yeah, school didn't really prepare me for kind of how complicated that would be.
How have you used your creativity in your work?
I think one thing we've been able to do, we recognize that I was kind of doing, and I'm sure other people can relate to this because I've heard a lot of people when I've talked about it, but I felt like I was doing the job of multiple people because there were multiple grants that I was written into. And it was really overwhelming for a time because there were so many things. I was doing Milwaukee County work, I was doing work. Providing consultation and technical assistance to our local and tribal health departments in the state, helping out our healthcare organizations who are implementing suicide safer care in their healthcare systems. And I was also planning our statewide conference. So there was like statewide and county work and just kind of random things that would come up. And so I advocated that we split the roles if we could get some additional funding. And we were able to increase our funding and hire our intern at the time. So she's now full-time staff with us. And we're able to kind of share the responsibility for some of these grants and really figure out, all right, how are these things going to be best accomplished and how can we do it efficiently without burning out one person? So now my work is pretty much only statewide, and her work is statewide with some Milwaukee County things built into it. And I think we're still kind of evolving and figuring out how do we divide staff responsibility and actually, move on some of these projects we want to do without being overwhelmed and stepping on each other's toes.
In my undergrad, I majored in psychology. So I did think a lot about going into social work after I graduated. And obviously, there were a lot of people in my major who were talking about that. It was a constant conversation, and what are we going to do next was always kind of in the air. And I remember what I would hear over and over again is social work, you graduate within 2 years, you're burnt out, and you want to move on and get a new career. And that was kind of a big factor for me. So, how long were you in your job with Mental Health America of Wisconsin before you advocated for yourself and talked about dividing up the job?
Yeah. I think about a year. If I'm really reflecting on it, I think I realized immediately that this is a lot of work, but I was really enthusiastic. It was my first job, and in college I filled a bunch of different roles, wore a million different hats, and so I was like, I can do this. It's no big deal. I'm used to doing a lot of things and being able to manage that. But then I think a year into it, I kind of realized this is not sustainable for one person. And some people would say this, people who had been in the role before. Um, and so I started advocating for myself and really thinking creatively about how we can divide up this responsibility. And so I'm glad that we were able to take steps to get additional funding and do it that way. But yeah, it probably took me about a year to really speak that up and not take it as a personal thing. Like, I'm not, it's not my fault that I'm personally burnt out. It's the job, the role is too big, and we need to think about how to sustain this if we really want to, do some real suicide prevention work in Wisconsin.
Do you remember that conversation and how you articulated it? Because I think that's really important for a lot of people, especially in their first job, out of school? Like, at what point do you tell yourself, no, just like suck it up? You gotta be tougher. You gotta be better. And when do you say, wait a minute, like, this whole premise is wrong? And yeah, I think communicating effectively to where you can convey that it's better for everyone that we rethink the situation. It's really important.
That's so true. I think you articulated it so well. And I think I used a lot of those words to communicate it. And it wasn't just one conversation. I think I had to talk with my boss a couple times, my supervisor, some people that I worked with, and then kind of people in my just personal support network as well. I remember talking with my mom about it too. And I would say that to her, like, well, maybe I'm just not working hard enough, or maybe I need to manage my time better. And she was like, no, like,
Mhm.
out of all the things you told me that you're responsible for, like, these, are a lot of things. And so I needed that constant support telling me that, like, it wasn't just me. So I had to email about it and really kind of get in writing that this isn't sustainable if it's just one person doing this, and bring it up multiple times. But that's definitely been a learning experience.
So, what is in your current realm of the job?
So now, as I so with the kind of change and responsibility, and it's been gradual too, so we've made like gradual transitions, but I did switch titles from suicide prevention specialist to suicide prevention program coordinator. So I currently serve as the state lead for suicide prevention. If you go to the Suicide Prevention Resource Center website, you learn about the different states. They have a state contact list for different state coordinators. So ideally, every state would have a suicide prevention coordinator. And so in Wisconsin, a lot of the things that I'm responsible for are coordinating our annual suicide prevention conference as a way to provide education and training to people who are doing this work. Still providing some technical assistance to our local and tribal health departments on adolescent suicide prevention. Um, so each health department can choose what objective they want to focus on, and for the ones who select adolescent suicide prevention, they're in a learning community with MHA. And part of my role is to support them. And then another big piece is leading the zero suicide training. It's the Wisconsin Zero Suicide Training that we did this year virtually for the first time, as well as the conference. But annually, we have a 2-day training, if it was in person, for healthcare system teams to learn about the zero suicide approach.
Wow, that is quite a lot to cover.
Yeah.
What would you say is the highlight of your position, and what is the biggest challenge?
I think the highlight, there's many highlights really, which is funny because people on the outside, if you're not familiar with suicide prevention work or social work, a lot of people are like, suicide prevention, like that doesn't sound like a happy job. And it used to bother me when people said that, but now it's kind of an opportunity to really talk about the work. And when I really feel fulfilled is when we're able to have conversations about how to move the field forward. I think so often we've been stuck in this mental health centric, like pathologized view of suicide, and assuming that the only thing that would ever cause suicide is a mental illness. And so, um, we at the conference recently, the theme was reframing the narrative. And I think there's a lot of ways we can reframe the narrative, but one of them is making sure we're elevating the voices of people with lived experience and not censoring their experiences around how they've been treated in the mental health system and in healthcare systems. And a lot of times, uh, social work field and the suicide prevention field doesn't want to hear that because some of it goes against what we've been saying so long, just kind of the basic things about reach out, if you need help, and help is available, but what happens when help isn't available? And so I think there's been some very vocal advocates for um, redefining the mental health system, and making sure we're not using the same like coercive, persuasive, they articulate it better than me, but the same tactics we've used so long in this field. So I'm really inspired by that. So I guess I could, yeah.
Can you talk more about how that mindset has changed about suicide prevention?
Yeah, I'm hoping that it's changing. I'm seeing kind of in my everyday work now how it's changing, and these conversations that are coming up because of the discussion that we've had at the Prevent Suicide Wisconsin conference about shifting how we do trainings or how we have these conversations. And I think people are understanding that, for example, if somebody tells you they're thinking about suicide, you don't have to immediately hit the panic button, and you don't have to immediately call a crisis line to have police come or have a mental health crisis team come. You can actually pause and sit with them in that moment and kind of figure out more about what's going on, and not necessarily doing like a clinical um, assessment or a screening if you're not a clinician, but just normalizing talking about suicide and not being scared away by these conversations.
That's really interesting. I hadn't thought about how those approaches ripple out and how we, like you said, when you say the word suicide, it tends to invoke panic. So, what would you say is the right approach if you are talking with a friend or a colleague and you're getting the sense that there is that inclination toward self harm or suicide? What do we do?
That's a really good question. And I think most importantly, we ask if they're thinking about suicide in the words that make the most sense to us. So you could ask if they're thinking about death or dying, if they thought about dying recently, and then ask more questions after that. I think if you're like talking with them via text or on the phone or something, it would be important to ask them at some point if they have access to what they would use to kill themselves, because then you might want to get other people involved, even a family member, to make sure, if they're in crisis and they're not really thinking straight, make sure that they don't have access to those things. But just ask them directly if they're thinking about suicide, and ask more about why. I mean, sometimes there's not a direct why, it's a variety of things, but not assuming it's something wrong with them. um,
Right. And then what's the next step? Is there a better resource out there that we don't know about?
I think once like the crisis has passed, if you want to call it a crisis, there are a lot of groups. In this virtual world, I'm still trying to figure out and compile everything that's available virtually to folks, and some things that are still happening in person. But there are groups like Alternatives to Suicide, and a lot of different peer-led models, which are really cool because they're not clinically driven, and a lot of times they're no or low cost. But we've been looking into how do we bring more of these alternatives to suicide groups to Wisconsin. So how do we um, have these peer-led services, and then even peer-run respites? So houses like that are home-like settings that people can go to in crisis instead of hospitals or emergency departments. So if they haven't, recently attempted suicide and they really don't need to be hospitalized, can they go to a peer-run respite or a drop-in center where they can talk with people who have also been there and can talk openly about whatever it might be that they're dealing with?
Can you talk to me more about Wisconsin Zero Suicide Training?
Yeah. So this is the one that's specifically for healthcare systems. When we did it virtually, we did it this year as a 3-day training, and we recruit organizations across the state who have an interest in implementing the framework, which is essentially 7 elements that make up the framework. Um, the first one is lead, and I'm going to get these out of order, but there's train, improve, engage, and treat, I believe, and transition. And so they're all very big elements, but when you break them down in this training, organizations learn about how to get buy-in for this new quality improvement initiative, and then talk about the trainings that you can offer all your staff, making sure it's continuous quality improvement and that you're having regular meetings about cracks in your system that people essentially might fall through if they are suicidal. um, and then yeah, there's really a lot to it, so I'm just kind of stuck on like where I should go without giving like the whole training as we're having this conversation. But it's really to make sure healthcare systems are safe for people with suicidal thoughts, and that's primary healthcare, like your regular doctor, and behavioral healthcare professionals as well. And we're trying to introduce more lived experience into that training as well, because historically it's been pretty clinical. We talk about assessments and screenings and all of these different clinical tools, but it's important that in Wisconsin, I think, it's important to include the activity that we include. We have, so similar to alternatives to suicide, this activity is called the attitudes or beliefs activity, and Val Neff has led it for the past few years at our suicide training. And she'll basically ask questions that people would go to one side or the other, like they strongly agree or strongly disagree with the statement. And the statements are relatively controversial statements, like I believe suicide is selfish, or I believe suicide is only acceptable if someone's terminally ill. And people kind of line up, and there's no right or wrong answers, and we just want people to kind of in the room figure out where they are, what they bring to the table, and then have a discussion about that. And so I personally think it's the most powerful piece of the training, because we're having very open conversations about what we personally believe about people who have thoughts about suicide, and sometimes we are people with lived experience ourselves, and so we could share from that perspective, and obviously that goes into our work. So I think it's important that we include that in the training.
Is this a required training, or is it something that people opt
So
into?
So people opt into it. Like I said, recruit organizations will put out a call for applications, and organizations have to make the decision that they want to commit to this ongoing learning community after the training. So they'll send a team of folks that'll be their implementation team. And then the organizations are with us for about a year, having quarterly calls, talking about how their implementation's going. And then at the end of the year, they'll submit to us an organizational self study, and that shows us where they were at the beginning and then where they are now. And we offer additional follow up after that year to make sure they're still following up on some of the things they were going to implement. So some organizations have really taken zero suicide very far. They've split into subgroups around some clinical pieces and then some community pieces. And some organizations are just starting, which is fine too. And we just want to figure out where everybody's at and what exactly they might need help with. And at that point, we can bring in some national experts or offer some one-on-one support.
How do you think that people who are in healthcare should present this to their employer if it's not something they've already been encouraged to participate in? Like, how do
Yeah.
they get information, and how do you recommend that they sell it to their employer that they should get in this
Yeah.
training?
That's an awesome question, because that can be so difficult, right? Like you as a whatever your role is in that healthcare system, you might just be one person and not feel
Right.
like you have a lot of influence to get leadership buy-in. So I guess it's about relationship building and making sure you're talking to the right people who can generate that buy-in. One example from Jefferson County, we have a zero suicide faculty member who talks at the training about they made zero suicide cookies. So they learned about the framework, and they had a small team that was really interested in zero suicide and wanted to implement this. And I might be getting this wrong, so I need to follow up with Kim to get the full story, but they introduced zero suicide as an idea with these cookies and a pamphlet about it, and let everybody in the organization know what it was about. And then they had a few meetings to do a couple presentations on it, and then they were able to create momentum that way. So I'm sure that's happened differently in each organizations, but that's a really good question. And now I'm kind of interested in how the organizations have come to us in the past. So we can only recruit so much, like promote it enough, because we know MHA knows about the training and about the model. But I think other organizations need to talk to other organizations about it, because they know the work better internally. I'm not a healthcare provider, so I don't know what the work looks like. So obviously, if you have other healthcare systems talking to other healthcare systems, I think you might get a little more buy-in.
You mentioned before how everything's gone virtual. Talk to me more about how your work has changed this year and the effects that you're seeing from people you're speaking with.
Yeah, it's been hard on a lot of people for a lot of different reasons. And one example is we offer through Mental Health America Wisconsin suicide loss support groups. Um, these were in the Milwaukee area before, the ones that we were able to provide a little bit of direct support to. But now they're all online. So we've been working with our facilitators to make sure they have the technology they need to host the groups, making sure we're getting the information out to participants who have participated in person before, making sure they know there's virtual options now. Um, and it's tough. We've had pretty low attendance, and we know that there's people who have lost loved ones to suicide who may be missing out on some support, and maybe virtual is not the right format for them. But for the few who have been able to attend, I think they've still been able to have really good conversation. So we're still going to continue that as long as we need, and maybe even past when we're able to meet in person again, we'll still have these virtual options, because they really are sometimes more accessible for people who might be traveling long distances, or for those who, like, the location that you have isn't accessible. So that's one example of how we've shifted online. And we've also hosted the Prevent Suicide Wisconsin conference virtually, which I just said this to someone recently, how we've kind of grieved that transition from moving to an in-person to a virtual conference, because we can't see everybody in person and we can't like be together. But it really surprised me how intimate it was still able to be in the Zoom sessions that we were in. And after the keynote, where we listened to people with lived experience of suicide talk about what really matters, and talk like from their heart about what needs to change and what hasn't helped. And I mean, there were tears still on a virtual format. And it was funny because we joked about, like, we didn't expect this to be as emotional on Zoom as it could have been in person, but we still really did get a lot out of it. And I think there's still a lot of hope in these virtual online events. I know we're all kind of burnt out on hearing the words virtual and online, but it is what it is, and we're trying to be creative with offering the support still.
Yeah, I think that alone together or whatever people say all the time, that's
I like
another
that.
one I'm pretty over.
Yeah,
And I'm
I
pretty
don't know if I've heard that yet.
over it being relevant also. I think that we're all just getting so burnt out by this quarantine phase of our lives.
Right.
But how would you say that your prevention services have pivoted now?
We're trying to figure out how to keep up the engagement and how to make sure we're really connecting with people rather than just presenting to a screen and you don't really know if they're taking what's like what you're saying in on the other side of the screen. Um, and our coalitions at the beginning of the pandemic, it felt like our coalitions were very interested in how to still offer support to people. We'd like to still offer these ongoing coalition calls to meet people, to meet some needs that maybe we don't know about. So we're considering having like drop-in calls to hear from people in all different counties who are still doing suicide prevention work that we just might not know about at Mental Health America, Wisconsin. But we know a lot has changed and we still have a lot of work to do connecting with people intentionally to hear from them.
What's a coalition call?
Good question. So, um, the coalitions, when I talk about the coalitions, we had, so Prevent Suicide Wisconsin is the like umbrella coalition for all of the different county coalitions. We have a whole list on our website, and if people want to get involved, they can check it out that way. But a coalition is basically just a group of folks interested in suicide prevention work. And sometimes they're attached to a nonprofit, so there might be some funding. But a lot of times, these are volunteer coalitions that have done suicide awareness walks or QPR trainings. That's question, persuade, refer. And kind of the most common suicide prevention training in Wisconsin right now, and a variety of other things. I mean, their goal is to implement the state suicide prevention plan. And so there's 4 strategies that they might look at and figure out what seems realistic in their area. And then we hear from them every year about what strategies they're working on and what kind of support we might be able to offer.
What are the 4 statewide strategies?
I love this question because it's my new favorite thing to talk about since we just released our state suicide prevention plan. Our 4 strategies in plain language would be increasing and or that's not really plain language, but basically, also I'll say them increasing and enhancing protective factors. So breaking down that strategy 1, making sure people don't become suicidal in the first place. So that's where we're talking about social emotional learning in schools, creating suicide safe environments, um, uh, talking about addressing trauma, um, a lot of other things. So that's strategy 1. Strategy 2 is access to care. So I talked about the peer led services already, making sure there's also some clinical services for substance use disorders, uh, mental health services, telehealth, telepsychology. And then the third is about the zero suicide piece that I talked about. So making sure we are working on best practices in healthcare systems. And then finally, the 4th strategy is about data. And so data evaluation and surveillance. Data surveillance is more about making sure we know who's dying by suicide in Wisconsin, what are the demographics, what are the rates, what are the risk factors. And the evaluation piece, which is kind of a huge gap right now, is making sure we're evaluating the programs that we're talking about. So, a big example of that is if we're doing question, persuade, refer trainings to make sure people can recognize when people are at risk for suicide, are we actually evaluating the program and making sure this is the best program that we could possibly be using? And again, that's just one example, but just making sure like the things we're doing are working and are recommended by people with lived experience and culturally relevant, all of those things.
What do all of us need to be doing to be better suicide prevention partners?
I think it starts with compassion. Recognizing that anyone can be suicidal. It's not, just a certain demographic. It's not a certain profession. Of course, there are people who are disproportionately affected by suicide. So when you look at the data, you can see, like, for example, LGBTQ youth in schools are at higher risk for thoughts and attempts of suicide. But recognizing that really it can, anyone for a variety of reasons could be experiencing thoughts of suicide. And I think just normalizing that conversation, making sure we're not making jokes about suicide, making sure we're not portraying suicide as something glamorous in the media, and also not portraying it as something problematic, like only talking about suicide when it's a tragedy. I think, that happens all the time in September when it's Suicide Prevention Month. Media will want to talk to a family that's lost someone to suicide, and will want to do that to sensationalize a story and get, um, you know, I mean, they'll say they'll want to raise awareness, but more than raising awareness, what are you actually doing to make sure services are out there for people? So I think just on a personal level, having that compassion and making sure we're talking about suicide in a safe and compassionate way, and then advocating for policies that can prevent suicide. And
Or
there's a lot of those. There's a lot of things other states are doing that Wisconsin isn't.
tell me. Tell me
Yeah.
more.
So we would love for suicide care trainings to be required in grad programs. And some of these policy things might not be legislative at a state level, but maybe program by program. But this one's kind of a multiple part one. We'd love for suicide care trainings to be mandated in grad programs for social work and different helping professionals, and then past just being in the program that somebody goes through being a requirement in the hours that people need for their licensure. So we had a bill that was drafted within the speaker's task force for suicide prevention that happened last year that didn't end up passing. There's things we can change about it, but its premise was making sure helping professionals are getting at least 2 hours of suicide specific education in when they renew their license, because it's rare that's a training that folks get.
You talked before about compassion
Mhm.
and how this really all comes down to a one-on-one interaction that we have with each other. And this is a really difficult time for basically everyone on earth. We're all kind of
Yeah.
going through a difficult time in our own individual way. And I think that, on one hand, there's so many people out there who want to do something good and want to do something big and impactful. And they think, well, I don't have a platform. Like, how am I supposed to change the world if I don't have a million followers on Instagram, or I don't have my own reality TV show or something like that? But really, with this specific thing, suicide prevention, this is about all of us just being aware of each other and checking in with people that
Mhm.
we care about and being present. And I think for so many of us, that's a more difficult thing to keep in mind on an
Yeah.
everyday basis, that we can make such a big impact just being good friends and good people. And I think that intellectually, we all know that people who are crying out for help can present in many different ways, and sometimes that can also be bullying and being difficult to be around. And in this culture right now, we do have a tendency to want to point out each other's flaws and shortcomings and call each other out, but sometimes that might not be what's needed. We might need to recognize the pain that someone is experiencing and not framing it in a positive or accurate way. What would you say is the way to do it?
That is a big question. What comes to mind, though, is I don't know if you've heard of mindful self-compassion. It's
No.
so I am not the expert. I have only learned from my good friend Barbara Moser, who's only recently become a mindful self-compassion teacher. And I admittedly was a skeptic because I am skeptical of mindfulness in some of the ways it's just been talked about. And maybe it's just my experience hearing about it in the wrong ways, having it be marketed rather than something um, that is a real thing that can help people. And so I was introduced to mindful self-compassion as kind of a combination of both mindfulness and having self-compassion. And at its core is basically you recognizing that the way, how do I phrase this? The question that they typically ask is like trained teachers is how is the way that you talk to yourself the way that you would talk to a friend? And oftentimes we say no because we're very hard on ourselves. And maybe this isn't true for everyone, but I think a lot of times we're a lot harder on ourselves than we are on our friends. If a friend makes a mistake, we're still going to be there for them and we're still going to um, be kind to them and have patience. But with ourselves, we're like, why would you do that? Like, why? Like, you're so stupid, or you're so, like, why would you forget this thing? I don't know. There's a variety of things that you can say, but there's a lot of different practices and themes in mindful self compassion that I've been learning a lot about recently that kind of helps you connect better to others. And so that's just one example. Um, of a way that we can just be there with each other and also have compassion for ourselves, recognizing that we're all human. um and I wish that I could explain it a little bit better, so I'm sorry that I'm getting a little tripped up, but that's what comes to mind.
Is there anything that you think people should know about suicide prevention and mental health?
I think in addition to the more kind of personal things we're talking about, a lot of things are suicide prevention that we don't label suicide prevention. So, validating and affirming people's identity. So, I'll use a gay straight alliance as an example. If the presence of a gay straight alliance or a GSA in a school decreases the suicide risk, the risk of thoughts of suicide for youth in that school and for all the youth in that school, because you have a group that validates, accepts, celebrates the identities of LGBTQ plus students. And then having other cultural groups or groups based around identity, because we know, like I said, LGBTQ youth are disproportionately affected by suicidal thoughts, not because they're inherently at risk, but because society tells them all of these really negative, hateful things. And that's the same with a lot of different groups. And so, back to that reframing the narrative theme, suicide prevention isn't just you having a conversation with one person and taking on the responsibility of being the one to prevent suicide. But I think suicide prevention is bigger than that, and making sure we have access equitable access to systems that are equitable to us, and actually this making sure the services are available, making sure housing is available. um, the CDC reported that only about half of people who, I don't mean to say only, but half of people who died by suicide had a diagnosed mental health condition. So this is about more than just mental health. It's about um, racial justice, disability justice, LGBTQ inclusion, and having a society that actually values all of the people in it and has services specifically for groups that are disproportionately affected.
Leah, thank you so much for sharing all of your insights.
Yeah, you're welcome. Thank you so much for letting me have this conversation with you.
Thanks again to Leah Rolando for giving us some of her precious time. Be sure to visit the Mental Health America of Wisconsin website at mhawisconsin.org for all of the resources they have available. Don't forget that all episodes of Lead the Way can be found on Spotify, Google Play, Stitcher, TuneIn, YouTube, and Apple Podcasts. Thanks to Buzz Kumper for his voiceover artistry in the opening. This episode was brought to you by the time and talent of Tyler Willenbrink, Annie Petrus, and Jeremy Van Mill. I'm Anna Gaucher. Until next time.